Okay, let's dive right into today's explainer and demystify a really dramatic pediatric condition, one that turns a totally healthy appetite into a sudden medical emergency. We're going to be looking at a fascinating, albeit pretty frightening, gastrointestinal disorder that pops up in the first few weeks of life, hypertrophic pyloric stenosis. We're going to break down exactly what happens in the infant's body, how providers actually spot it, and the incredibly effective way it's treated.
Now picture this. You've got a ravenously hungry infant, but instead of just a normal spit-up, they suddenly project their meal up to 4 feet across the room. What's really interesting about this question is that it highlights the terrifying hallmark symptom of what is essentially a purely mechanical problem in the gut. I mean, it sounds like some complex systemic issue, right? But as you'll see, it really just boils down to a localized physical roadblock. To understand how this works, we'll follow the clinical journey step by step. We've got 5 parts. 1. The projectile vomiting infant. 2. Anatomy of the blockage. 3. The real danger of dehydration and alkalosis. 4. Diagnosing the obstruction. And finally 5. The surgical solution. Let's get into it.
Section 1. The projectile vomiting infant. Recognizing the early clinical manifestations. Let's look at what parents and providers actually see when this condition kicks off.
So here is the really crucial point. Despite violently projecting their food literally 3 or 4 feet across the room, the baby isn't actually in severe pain. They're just chronically hungry. In fact, they'll eagerly try to nurse again right after vomiting. Because the food can't pass through, you'll see poor weight gain. And fascinatingly, if you look closely at the infant's abdomen, you might actually see visible waves moving from left to right. That is the stomach muscle working in absolute overdrive, cramping and rippling as it desperately tries to push food past a blocked exit.
And is highlighted in the handwritten pediatric clinical notes from our W5 sources. It's absolutely essential to monitor exactly what is coming up. The big thing to look for? The lack of bile. That non-bilious vomit tells us something vital. The obstruction is happening high up in the digestive tract, way before the food ever reaches the small intestine where bile is introduced. Section 2. Anatomy of the blockage. The plumbing problem. To figure out why the food has nowhere to go but up and out, we've got to look at the anatomy. Let's break down the name itself. The H in hypertrophic pyloric stenosis stands for hypertrophy, which simply means the muscle tissue has grown abnormally thick. Basically, the circular muscle of the pyloric sphincter, that's the gateway between the stomach and the duodenum, just starts to thicken up. And keep in mind, this isn't something they're born with. It develops over those first few weeks of life. And this image perfectly illustrates the plumbing analogy. That pyloric valve has thickened so much that it completely obliterates the channel. The space inside the pipe is just gone. Over time, inflammation makes whatever tiny opening is left swell shut, leading to a complete obstruction. So the stomach fills up, the pressure builds, and boom, projectile vomiting. Moving right along to Section 3, danger, dehydration, and alkalosis. Let's look at the metabolic consequences of all that continuous vomiting. You see, the immediate danger to the infant isn't just starvation, it's what they are losing every single time they throw up. Because they're losing massive amounts of gastric juices, they get aggressively depleted of water and vital electrolytes like potassium and chloride. Crucially, they are losing stomach acid. When you lose that much acid, your blood pH shoots up, leading to a dangerous state called metabolic alkalosis. Plus, their BU, or blood urea nitrogen, goes way up, which is a massive red flag for severe dehydration. Now, here is a vital clinical pearl straight from the W5 pediatric notes. You have to look closely at blood sodium levels. Even though the infant is losing electrolytes overall, the rapid drop in body water means the sodium left behind gets highly concentrated. So a blood test is going to show an artificially spiked sodium level. That's your siren going off, signaling severe dehydration that needs immediate attention. But wait, medical providers have to be incredibly careful here. The notes give a massive warning. Correct too rapidly, water intox possible. If you just rapidly pump the baby full of water to fix the dehydration without carefully balancing those electrolytes, you'll stretch out the cells. That rapid fluid shift causes water intoxication, which can honestly be just as deadly as the dehydration itself. Because of that risk, before any surgeon even thinks about fixing the stomach, providers have to follow a strict stabilization checklist. If the infant can't keep anything down, often charted as no PO or nothing by mouth, IV fluid therapy is the immediate go-to. They systematically rehydrate the baby and gradually correct the metabolic alkalosis. This stabilization phase smoothly sets the stage for safe surgery,
even if it means delaying the operation for 24 to 48 hours. Section 4, diagnosing the obstruction, finding the culprit in the clinic. Once the baby is stabilized, we need to confirm what's actually causing the blockage.
And the diagnosis often happens right there in the exam room. If the baby is calm and their stomach is empty, a provider pressing on the upper right abdomen can often feel the thickened muscle itself. It literally feels like a distinct olive-shaped tumor just to the right of the belly button. Finding this olive is the absolute classic hallmark of the disease.
But hey, sometimes you just can't feel the olive. When that happens, providers don't just guess, they turn to imaging. Ultrasound is the standard go-to here, revealing an elongated mass around a really narrow pyloric canal. If the ultrasound is somehow inconclusive, they'll use an upper GI radiograph to quickly see the blockage and rule out other issues like malrotation.
Section 5, the surgical solution, opening the pathway. With the diagnosis confirmed and the fluids balanced, it's finally time to fix the plumbing. The standard fix here is a surgical procedure called a pylomyomyotomy. It's actually incredibly straightforward. Often using a laparoscope, the surgeon makes a precise lengthwise slice right through those tight, thick muscle fibers. They cut just deep enough to relieve the tension without actually breaking the inner lining of the gut. Just like that, the channel pops open and the blockage is gone. Honestly, what's truly amazing is how fast these infants bounce back once that muscle is released. Within just 4 to 6 hours after surgery, the baby can start taking small, frequent sips of water or an electrolyte solution. By 24 hours post-op, if they're keeping that down, formula is introduced. And in just 48 hours, they're usually right back on a completely normal, full feeding schedule. It's like it never even happened. Thanks to observant parents catching the symptoms early, careful fluid management preventing water intoxication, and this incredibly successful laparoscopic procedure, the mortality rate for this once terrifying condition is now exceptionally low, sitting between 0 and just 0.5%. It is a phenomenal medical success story. It really makes you wonder, doesn't it? We took a situation as chaotic as projectile vomiting and severe dehydration and traced the whole shebang back to a single, slightly overgrown band of muscle. It begs the question, what other incredible medical mysteries are hiding right beneath the surface, just waiting to be explained by a simple shift in anatomy? Keep that in mind as you continue exploring the fascinating mechanics of the human body.